We have a case narrative we want to share it with you. She was a 39 years old female patient, came up with the cyanosis in her left second toe and erosion of its tib. Lubrication stopped the condition in her left butt and thigh after walking 100 meters. She is obese and her both common femoral pulsations were equal and weak, as were her pedal pulses. Duplex examinations uncovered 6% stenosis in her infrarenal aorta midway between the takeoff of the renal arteries and the aortic bifurcation. CT was congruent to what we had found on the duplex examination. Her laboratory investigations were unremarkable for the lipid profile as well as for the biomarkers for arthritis. Under spinal anesthesia, we went up through right common femoral cut down, and the scout angiography revealed this picture. We put primary stent that was wall stent 40 millimeter by 40 millimeter lens, and we used the post dilatations with a Mustang balloon matching the same diameter and length as of that of the wall stent, and this was the completion angiogram of her procedure. Back to the mid-aortic syndrome, it has several etiologies. Number one, it could be an idiopathic in 6% of the cases, or as a consequence of the aortitis in 26%. Atherosclerosis represents 5% of the cases. Neurocutaneous syndrome in 5% of the cases, and Williams syndrome in 2% of the cases, and in other conditions it might be as a consequence of radiation arthritis or following surgery over the aorta. The idiopathic has different locations, may be intrarenal in about 50% of the cases and suprarenal in up to 40% of the cases, and in locations in the infrarenal, as our case, ranging from 19 to 25% of the cases, and it could be diffuse in 12% of the cases. The gender preponderance, it's almost in 50% of the female, and the remaining are males. The pathogenesis is speculative, cannot be exactly determined whether it is failure of fusion of the two dorsal aorta or rubella infections during intrauterine life, or an abnormal migration of the kidney because of the higher frequency with the finding of ectopic kidneys. The histological findings may be fibroplasia of the intima, distortion of the internal elastic lamina in absence of the inflammatory changes. Aortitis, which occurs in up to 25% of the cases, most commonly the tachyarthritis, granulomatous inflammation, deposition of the autoimmune complexes in the aortic wall, resulting in stenosis of the arterial lumen and outflow impairment, and there may be aneurysmal dilatation like this case. Also, dissections can complicate the conditions and the stenosis like this form. Neurocutaneous syndrome, which represents 5% of the mid-aortic syndrome, it occurs in neurofibromatosis type 1. It's an autosomal dominant inheritance, and it affects the chromosome 17. 50% evolves as a mutation. Skin and eye affections are universal in all of the cases. Brain and the spinal cord can complicate 50% of the cases. Occasionally, bone and arteries are also affected. This is the cutaneous manifestations which happens in the neurofibromatosis type 1. Lastly, the Williams syndrome. This Williams syndrome is rare. It affects 20,000 of cases of the United States. There is a common medical, neurological, and behavioral changes. These patients are affected by affections of their ability to calculate, like the abstract reasoning and numbering. Cardiovascular disorders can happen during their course of life. They are characterized by being social, friendly, and endearing, with special predilections for the music. Thank you very much.